Hey, are you there?
John, can you hear me?
Yeah. Hey, how you doing?
Pretty good, John. When are we starting?
About 20. Let's see. About
Okay. I'm all set.
About 15 minutes.
Sure, John. I'm just getting all the videos and all that organized.
Okay.
JKBC is
Okay. JKBC is not lecturing first.
yeah. Okay. All
Is
right.
Dr. Parthaban going first?
Yeah. Yes.
Okay.
Yeah, I'm just showing the cavernous sinus dissection actually here. I'm just showing the optic nerve decompression. Yes, yeah. Yeah, John, give me a minute. Yeah, so yeah, what I'm doing is actually I'm organizing this.
You're organizing what?
No, I'm just talking, John. I'm just talking here.
Oh, okay.
Maybe I need to just mute. Hello.
Yes, hello.
Hello, Professor Johnson. Hello. Hello, Professor Johnson. Hello. Hello, Dr. John. मैं फोन कर
Jackson.
Какой пора достичься? Хиндуэсом.
Гинеколог конференция. Нормально.
Çıkardım arada. Mama. Niye yiyorsun sana?
Hello, is Dr. John there? Hello.
Hello and good afternoon. Azerbaijan.
Dr. Parthaban has arrived. Hi, Dr. Parthaban, are you there? Good morning,
Hello.
Dr. Parthaban.
Good evening, Dr. John.
Hi.
How are you
Hi.
doing?
Morning. Good evening. Hi.
Okay, you're all set?
I'm set. Yeah, I'm ready.
Okay, we got about 3 minutes, okay?
Yeah.
Hello. Good evening, Dr. John.
Hey, how you
Hello.
doing?
I'm good, sir. I'm Dr. Uday speaking from India.
Yes, welcome.
I'm not able to receive the regular updates for the email updates for when of the scheduled meeting.
Okay, yeah.
Hi. Good to see
Vanakkam,
you.
Talagare.
Yeah.
Okay,
yes,
leave your email there, okay? On
the
the
background
chat
is very
box,
good.
Uday.
Okay.
Okay, Uday, leave your email in the chat box
Okay.
to make sure you get, we'll put you on the mailing list. Because generally I email out a couple times prior to the broadcast.
Okay. Thanks, sir.
Okay,
Thank you.
okay.
Thank you.
There you go. I see LCs. Yeah, anybody that wants to get on the email list, just put your email in the chat box. I'll put that message in now. And also, I'm going to put the okay. There you go. I got 4 emails. Good. Okay, Dr. Parthaban, you ready?
I'm ready. I'm okay.
Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from Miami Beach. This is Dr. John Bennett broadcasting for Neurosurgical TV. We have another episode in the daily dose of neurosurgery education, headed by Ipterian. Today we have another presentation by Jody Parthaban, neurosurgeon from India. And I'll just let him take over. And welcome, Jody, and it's all yours.
Hi. Nice. Good evening and good morning to friends. Are you able to see my slides?
Yes, you want to make it bigger or?
I'll make it, yeah.
Okay. There you go.
Is that okay?
Yeah, perfect.
Right. It's nice to meet you again today. This week, I like to take you through a new approach as a, retropharyngeal approach to the upper cervical spine. Last week, we saw the subaxial spine. Now, this time we'd like to focus on the upper cervical spine. So reaching upper cervical spine is very interesting subject, but at the same time, you need more understanding about some of the simple anatomy over there. Now, this approach is not a new one. It is a very old approach, right? Initially, it was defined by Stevenson's as parapharyngeal approach, which is a T incision in the neck, T incision. It was done in 1966. And later on, it is by Whiteside and Kelly in 1966 again with Verbeest. They call that as lateral cervical retrocarotid. Retrocarotid means posterior to the carotid, that means lateral to the carotids. So that was another approach. And Riley in 1973 again described similar approaches to the upper cervical spine. However, the transcervical retropharyngeal approach, what we do now, was earlier defined by McAfee, Robinson, and Southwick. There are small adjustments, small changes, but apart from that, the basic is the same. Like last time I told you, the deep cervical fascia has to be divided in such a way we can reach the prevertebral region. Now you can see in this picture, the upper cervical spine is coming more or less parallel to the mandible, the angle of the mandible. When the spine, when the neck is extended and you make the mandible to go away, then you can reach the upper cervical spine easy. The easiest cervical spine that you can reach at any time is C4, C5, and C6. But from C3 above, it's a little difficult because you have the jaw and also the pharynx, the larynx. And so you find it a little bit difficult. It looks as if it's difficult, but it is not so. It is very, very simple. So reaching the C1, C2, C3 becomes more important because a lot of diseases come at that region. So we need to know the approach. In this picture, you can see the upper cervical spine, that is C1, C2 can be approached through a transoral approach. In the midline, you can see there is, in the middle, you can see a picture of the skull where the jaw is open. You can see C2 and C1. This is our classical transoral approach. But if you extend the mandible, the right side, you can see the picture which shows the needle is pointing up to C2 vertebral body. So that means that by extending very nicely and keeping the incision far above, when compared to the subaxial cervical spine incisions, you can reach those areas very nicely, though it is deep. Now the gray line, the gray area zone, you can see on the left side, which shows that you can reach from the lower aspect of the clivus, C1, C2, and C3. And if you extend it, then you can even go for C4 and C5. So up to this region, you can approach through the retropharyngeal approach. Now, this is the classical incision types. You can see C4, C5 is very quiet comparatively of the thyroid cartilage, where you can easily palpate. And C3 is slightly above, is the heart. And C1, C2, for C1, C2, it is submandibular. So you have to know about understanding, but it may not be the same, because in a thick neck, these things will change. So this is for a normal, a thin anatomy, normal anatomy. Now on the right side, you can see the diagrammatic approach of the retropharyngeal cervical approach, anterolateral cervical approach. Now I'll go through, take you by step, and you can see in this picture, the patient is anesthetized, positioned, and the neck is well extended. You can have a look at the incision. The incision is slightly lower to the mandibular border. The anterior retro or the extrapharyngeal approach is an excellent route to address the upper cervical spine pathologies. The lower part of the clivus, C1, C2, and C3 vertebral bodies, and the D space. At the D space and C1, C2 facet joints can easily be exposed in this approach. It is easy in thin built and long necks. Though it looks deep and tunnel-like, a good dissection can make the visibility better, especially with microscope. I'll show you by steps. Now you can see the position of the patient. This patient can be positioned nicely, and you can take a C-arm picture and keep it for your reference. The anesthetized patient is positioned supine and the neck is well extended. The chin is turned to the opposite side by 30 degrees and the head rests on over a ring. The rotation of the mandible to the left side provides a free access to the upper cervical spine. This is very important to achieve a clear vision over the field, and the microscope can easily be angled during entire surgery. Skull tongs will help you in trauma patients to facilitate traction or usually immobilize the patient while surgical procedure. Fluoroscopic images can be obtained to assess and to see the details of C1 and C2 alignment with localization of the target area. Whatever you want, you can reach the full extent of clivus to C3. The skin incision is marked 1.5 to 2 centimeter below the mandible from chin to angle parallel to the inferior margin. At both ends, the skin incision can be extended. You can see the marking very nicely. This is a very classical marking of submandibular mark for the retropharyngeal approach. And once you open the subcutaneous area, you find you may be having a lot of fat. You have to expose the platysma. Now here the dissection is just like a cadaver dissection. You cannot limit the dissection. The dissection must be very good. The skin is incised and the subcutaneous dissection done widely on both sides so that the exposed area is large. The platysma is visualized and meticulous dissection is ensured. Stay sutures are placed at subcutaneous layer and the surgical area is kept very wide. No need to get worried why so much of wide, but only when you make such a wide incision, you can reach your target. After that, the platysma is lifted up. The platysma muscle is first split from the mandibular symphysis to the median notch of the superior thyroid cartilage. The subplatysmal dissection is done very, very meticulously, and the muscle is cut horizontal to the entire breadth of the surgical exposure. The cut edges of the platysma are then everted and placed with stay sutures. This step exposes the deeper structures. This is a very important step. The platysma should be meticulously cut. Now you can see the moment you expose the platysma, you will find the pretracheal muscles. You will also find the facial artery. There is no need to ligate the facial artery, though I have shown you there. It is not needed at all. The facial artery comes very, very lateral. So one do not need to disturb that. Further dissection of the deep cervical fascia exposes the pretracheal muscles. The fascia over the submandibular gland. You can see the submandibular gland and the facial vessels just posterior and inferior to the gland. You can see the facial artery. The facial vessels need not be cut for exposure. Surgeon can see the groove lateral to the laryngeal cartilage and can palpate the structures gently. The carotid is palpated lateral to this groove. I will just show you this one. You can see this is the groove I was mentioning about. This is the facial artery. It's a facial vessels here. We don't need to go there. Our interest is here. Thyroid will be here. The hyoid will be there. So you have a small area you can see here. And this region you can palpate the carotid artery. This region will have the submandibular gland. Here you will have the submandibular gland. Now, this is the next picture. Now you can see very nicely the submandibular gland is very nicely dissected and exposed, and the gland is exposed. In a few occasions, one can find a very large gland. Sometimes you find a very large gland. It may not be small. Sometimes it will be very, very big, which may need a partial excision. But generally, the gland is preserved. The gland need not be cut. Generally, it is preserved. The inferior end can be lifted to visualize the glistening digastric tendon. I'll show you. Now you can see the, are you able to see the gland there is being lifted with an instrument? And in the next picture, you can see with the Langenberg retractor retracting the submandibular gland, you can find the glistening yellow digastric tendon. This digastric tendon is very important to find this digastric tendon, because the tendon passes through a facial sling that is attached to the greater wing of hyoid. I'll show you here this region. You can see here, this is a sling. This is the digastric, this is the digastric ligament. You can see that tendon here, and this is the sling, and this is a hyoid here. So if you can cut this, and this digastric become very loose and it can be retracted up. The reason for that is when you retract, when you go deeper and deeper, you may need a little bit of more retraction, and that will be facilitated by cutting that sling. The facial sling is attached to the greater wing of hyoid. To facilitate easier retraction of hollow organs, this sling should be cut and the tendon is released. In the next slide, I'll show you the next slide. And yeah, now you can see very beautifully the digastric tendon is released. Just below the digastric tendon, you can see the hypoglossal nerve just below the tendon, and it runs parallel to it. There is no need to try to dissect it, just leave it. By dissecting the deep cervical fascial layer between the laryngeal cartilage on the medially and the carotids on the laterally, the corridor for the surgical approach is now created. Once you create this, the surgeon can palpate the carotids, the lateral border of the exposure. Now I'm talking about this region, this area. You're able to see this area? Okay, this is the area where we have to focus on. So that's the most important. Now you can see here, that is the retrapharyngeal. Now you use the Langenberg. The greater cornu of the hyoid is palpated, and the superior pharyngeal constrictor muscles are retracted medially. The Langenberg, which you see on the upper side, not on the left side, but on the upper side, maybe on the right side, it retracts the hollow organs, and the carotids are laterally placed using right angle retractors. And using the cotton peanuts, as I told you in the subaxial cervical spinal approach, the loose areolar tissue are dissected to reach the prevertebral fascia over the upper cervical spine. The dissection is done over the desired area by adjusting the retractors. You have to adjust the retractors in such a way so that you can reach the complete entire anterior aspect of the vertebral body of C3, C2, C1 anterior arch. The pharyngeal muscle is lifted up and retracted superiorly and medially to expose the anterior arch of atlas. So this is the most important aspects you can see here, and that retractor, the most of the thing is very simple retractors what you use for every cervical spine surgery. These simple retractors can be used, like you can see here in the picture, very nice and anterior instrumentation is done. For superior exposure, the right angle retractor should be long. We should have a long retractors. Narrow beavers retractors can also be used if you have C1, C2 facetal screws, C1 lateral mass, and C2 body plates and screw fixations, C2, C3 anterior instrumentation, and ventral screw fixation of odontoid fractures can be done through this approach. Now, once you master this approach, you can expose from C3 up to lower border of clivus. That's all. But this, you believe me, you do not cut anything. You don't tie any artery. It's just the facial, areolar tissue you have to dissect very, very meticulously. The exposure must be wide. The dissection must be like what you do for a cadaver dissection. When you do for our basic education, we do a nice cadaver dissection with a long incision. So once we do that, this exposure is nice. Now, I will show you some of the case examples how we have done with this approach. So this is after the surgical procedure is over, you can use simple, that's all. Put back the platysma together, and after keeping a perivertebral drain, and then you close it. The skin incision is very nice, it comes up. And you believe me that you cannot even appreciate it after a few years that there was an incision because it is below the mandible. Now I'll show you this. What you see on this slide is the operation I did in 1991 and 1992. This is with Anderson type 2 odontoid fracture, and it was operated with a ventral screw fixation. This was done through this approach. Now, when we do this approach, we know that we can reach the base of C2 vertebral body, from where you can insert the ventral screw into the odontoid process. This was done with a single C-arm, and was published in 1994 in Neurology India. Probably this is the first case reported in the Indian literature. What is most interesting in this case is that if you carefully look, we have not used any sophisticated screw systems. This is just a malleolar screw system, which is used by the orthopedic surgeons to fix the fractures of the lower limb bones. And the same screw was used in those days. Never had cannulated screws in those days, but but in spite of that, we were able to achieve one of the best results you can achieve with the simplest screws possible. And so this is a very landmark paper, which was published in 1994 and followed by most of the surgeons in India. If I remember correct, there were interesting topic. Myself and Goel and Romania, we all presented in 1994. We presented in a conference where Professor Goel also presented a type of fixation of odontoid. It was wonderful. We spoke for 3 minutes each in a 8-minute or 9-minute talk. So we divided 3 speakers in 1 talk. That's very interesting. Now, similarly, we started using more such cases. We started doing more number of odontoid fractures through this technique. But now we have percutaneous techniques coming. There are, you have a different type of screws, very sophisticated. You use double C-arm, and so it becomes more easier and easier. But what I'm trying to say is that Now, every hospital or setup may not have all the facilities. Now, if you don't have the facility, do not get disheartened. Don't think it cannot be done. It can be done. It can be done like this, and you can see the base. You can see the base of C2. Watch here. You can see the base of the C2 vertebral body by yourself, your eyes. You can see. You can come to the center of the C2 vertebral body, nibble it, and guide the screw very nicely into the odontoid process. So odontoid fracture can be easily done with simple instruments. No need to get worried that I don't have the specialized cannulated screw. I don't have two C-arms. There is no need to worry about it. So I think the surgeons should, the young surgeons who don't have that kind of facilities, do not get disheartened. You can proceed with this retropharyngeal approach. It's such a beautiful approach. Once you open it, you have an exposure of such a large space of cervical spine. Your assistant must be very good. You have to teach your assistant how to retract that pharynx. The pharynx has to be retracted up and medially and also superiorly. So that is enough, because anatomically pharynx will move very nicely up like this, and then up and move it medially. The whole place is exposed to the surgeon. With a microscope, you can see wonderful anatomy. Now, with the same principles, we have done a humpty number of Hangman fractures. And Hangman fractures can be approached anteriorly. Hangman fracture can be approached posteriorly. It does not matter. But here, I have done so many of Hangman fracture only through this retropharyngeal approach. So Hangman fractures can be operated like this very simply. You can reduce it easily. You can put the interbody grafts and fix the implant. You can see this is the step by step. You can see from the upper up, you can see the mandible, you can see the mandibular gland. Retract the mandibular gland. You can see the sling. Cut the sling. Move very medial to the carotid artery, and then you dissect with the areola tissue. There you are there. Now you can see the plate. This is very simple cervical retractor. There is nothing special there. Absolutely nothing special. A simple retractor is good enough for you to reach and fix the spine. Now this is a very beautiful case. I have to all these cases are done 20 years ago, my dear friends. I'm telling you, these are not now. This is a doctor. She's a young doctor, a lady doctor, a gynecologist, who had neck pain, found very difficult to bend forward, was not eating well. She was finding it difficult to swallow. And when the X-ray was taken, there was a prevertebral shadow at the C2, C3, and C2 was collapsing over C3. And the MRI shows such a large retropharyngeal abscess. Can you imagine? You can see a big ball there. On the left and lower side, it is a big ball. Now, you can see the C3 is posteriorly displaced, and we do not know. Probably this lesion is a port spine. It's a port spine. And then we encourage her to undergo for surgery. We use this retropharyngeal approach. In this case, the abscess was opened up, drained completely, carpet degranulation, debridement was done, granulation tissues were removed, anterior cord was decompressed, a grafting for the iliac crest was placed, and a large plate, a long plate. What plate? You get surprised. And you can see the kind of screws. They are just AO screws, simple cortical screws, 20 years ago, 25 years ago. Now this patient had recovered very well, and she went back to the work after some time. I don't want her to tell the name of the doctor, but she is one of the very famous doctors now in Kerala. Now you look at this patient. She came to meet me after 20 years. After 20 years, she one day appeared in front. You look at the plate we use is a reconstruction plate, a simple reconstruction plate which was available those days. And even today, the spine is fixed very nice, diffused well. She's doing extremely well. Now, why I am trying to tell is that what you need is a very simple systems, but your exposure should be good. You can do wonderful job. You can do wonderful job. You can see the exposure has given approach up to C4 in this case. Now we not only use in this kind of cases. Now you look here in this C1 and C2 port spine. We common in India. C1, C2 port spine common in India. People come with neck pain, torticollis, and usually the recommendation is you wanted to confirm the lesion. You want to take the biopsy. Now either you go from posterior or you go from anterior. Sometimes the abscess is very large. You have to drain that. So the routine practice is sometimes you have to go to the transoral approach. Then you have to breach the posterior wall of the pharynx. But instead, you can always go through the retropharyngeal approach and evacuate enough of the cold abscess. The patient get relieved of pain if the joints are not involved. If the joints are involved, probably you may have to fix them or fix them with implants. If it is not so, you just have to reach that area and you can take the biopsy there. Now this approach you can see on the left and upper corner, the same retractors, nothing no more special. The cotton ball is now over the lesion. You can see the K wire or wire, whatever is over the lesion. And then you can see the granulation tissue there. Longest muscle must be retracted, pushed laterally so that you can find the abscess over there. And once you get the abscess, you can drain it. Now you can see here, this region, this region. The possible. Can I show one video now? I'll show one video. Maybe.
Sure.
I just try to see how I can get that video. Yeah. John, are you able to see?
Yes.
Yeah, you can see this video now. It shows
Yes.
that's the retractor. Now that is the longest musculi. I'm pushing the longest musculi on one side. You can see nicely. So the assistant must retract this very nicely. This is the medial retractor, superior and medial retractor, and this is the exposure. And this is the mandibular gland. You can see the mandibular gland. This is the carotids here. Now you can see this is the probably I think this is C2. Now we go up to C1. The longest musculi must be dissected very nicely. So this approach, now you can see that. See, when you retract more and more, you can see more and more. I'm telling my assistant to push that, take it up, take it up, take it. Yeah, that is very important. So you should keep on driving your assistant. That is most important. So you can use long monopolar cautery to divide the longest musculi, and so that you can reach the C1 and C2 facet region, so that you can expose the, that is the peanut. With the peanut, you can clean that area. You can see there is something white you can see here. That's abnormal structures. So once you retract higher and higher, you can reach your pathology. So this is up to C1 and C2 region. So yeah, so I'm just now making a cut over the longest musculi. I'll show you the next video, which will be more clear. Yeah. Now you can see I've already opened it. Now I'm removing the granulation tissue. And see that I'm removing that's a granulation tissue for port spine. You can remove the granulation tissue as much as possible from that area. You can use the curettes. You can use the punch. You can see that it is coming. Cord abscess will drain from there. Cord abscess, you can see the granulation tissue coming. You can press over the longest musculi. The cord abscess get drained, and by this way you can, here you can see that this region. So once you make it one entry, that is good enough. Once you make one entry, it will come very nicely. Watch that. See that? Yeah, it's coming. It's coming nicely. So this is why I'm demonstrating, is just to see the exposure. Here you can see that nicely. Yeah, good. That's nice. I'll go back to my presentation. So that's the presentation. You can see here, this is the granulation tissue. You can take it up and C1, C2 cold abscess, which is very common in India and also many Southeast Asian countries and all over the world. So how to take biopsy is the biggest problems. The transoral biopsies are nowadays, maybe you'll get very small tissue. From here, you get a large tissue. If a large abscess can be drained. Now, similarly, and sometimes you may have to excise vertebral body tumors. In this case, you can see one of the tumors. We use the same technique to remove the tumor and then fix with the with anterior plating at C2 and C4. And this sometimes you get into problems with the complex fractures of C1 and C2. Here the C2 vertebral body is smashed in a different fashion. I was a bit worried what to do. So try to fix with mini plates those days. So mini plates, we fixed it so that, you know, they get together, these pieces, because I find it in flexion. The C2 was falling forward. C1 was also fractured. And then after fixing this, we put Philadelphia collar. Beautiful fusion was there. And look at this kind of fractures. C2 fracture down with C3 flex over and extrapharyngeal, transpharyngeal, that is extrapharyngeal approach has given us such a beautiful execution of anterior cervical stabilization on this issue. So I like to conclude by saying that retropharyngeal approach is an excellent procedure, excellent approach, which can be used for pathologies from clivus, C1, C2, and C3. I like to recollect one important discussion. I think Goel is there.
Yeah, I believe he is. Dr. Goel, are you there?
Okay, he's not there.
I'll try to get a hold of him.
Okay, he may be coming, right?
Yeah.
I'll try to. So this is my concluding slide. Dr. Goel and myself, we were done in 2000. I think if I remember correct, it was the year 2000.
John, I'm listening to Parthi's
Yeah.
comments. Okay, Parthi, go ahead.
Goel, I hope that you remember in Madras, in Chennai, in 2000 skull base meeting. We were discussing this matter with Arnold Menezes.
Yeah.
Do you remember?
No, just go ahead. Let me just listen to the whole thing.
Yeah. Arnold Menezes was telling, because I was trying to do a odontoidectomy through this approach. So he was telling that it is very difficult. It is so long. It is deep. It is tunneling, and it is very difficult. But then actually this approach, we can always use it for all this kind of procedures. That time we had an excellent discussion on this matter, and I remember Professor Goel was there, and he was also discussing about this approach. I recollect that memories. Thank you very much for kind listening. Thank you very much.
Okay, very good. Thank you, Dr. Parthaban. Okay, we'll open it up immediately for comments or questions. The floor is open. Let me get you off there, Jody. Okay, questions, comments? I can read some, Jody, from the chat. Let me just get a hold of the chat here. Okay, we have a question from Arjun Dar. How did the C1, C2 cold abscess patient present clinically? And did you get a preoperative CT cervical spine and CVJ done?
Yeah. See, generally C1, C2 tuberculous patients, they present with neck pain and sometimes with torticollis. Neck pain and torticollis is quite common. And so the patient which you saw at C3, C4 is different, but C1, C2, usually they present with neck pain and torticollis. We always used to take a CT scan. CT scan give a very nice picture whether the joints are also involved, and you can nicely see the how much joint is eroded. I have not gone into the subject. That is a different subject. Maybe in some other time, I can speak on C1, C2 tuberculosis, C1, C2 tuberculosis joints. So most of the cases we do X-rays, CT scans, and MRI all together. Yeah.
Chandra Mooley asks, do you use traction during the operation?
No, we not for C1, C2 tuberculosis, but if there is a fracture dislocation, like for example in Hangman fracture, and in the kind of the C3 and C4, we don't use the traction. That means the traction is used only to stabilize the spine, and most of the other thing is done by your surgical technique. We don't pull too much of traction. No, we try to avoid that.
Someone asked, do we need to
Hello?
cut the digastric tendon?
No, no need to cut the digastric tendon, but you can cut the sling. Once you cut the sling, the digastric tendon moves up. Don't cut the digastric sling, digastric tendon, no.
Can you use instrumentation in TB infections?
Yes, we do. Yes, very much. You can see that you saw one of the cases, the patient which we have used. Tuberculosis is not contraindication for instrumentation. This doubt was there forever and ever and ever, but it is not so. In tuberculous spondylitis and tuberculosis abscess, where there is a instability, you can always evacuate the pus, you can degranulate the lesion, you can decompress, and then put and assemble, and then you stabilize this with implants, no problem.
Okay, Dr. Abhinav asks, have you seen implant failure post-anterior fixation surgery?
Oh, very less. I'm very sorry, but I'm very less. In my experience, is very less. I'm talking about a honest one, because the way we learn was very gradual. It is very gradual learning, very perfect learning, not in a hurry. So very less complications. Yes.
Okay, can we turn the patient's head to the contralateral side if we want to perform anterior C1, C2 transarticular fixation?
Yes, you can. You can turn. You have to be very careful when you do C1 and C2 facet screws, but you cannot turn too much also, because sometimes you have a dislocation. So if you have a dislocation, it is very difficult. I have not tried very many cases of C1 and C2 translocation cases through anterior approach. Yeah.
Can you reach into, Dr. Kavanaugh asked, can you reach into a C5 with the same incision?
Yes, you can, but you can, if it is a long incision, maybe sometimes you may need to make a T, that is like a Stevenson's. After the horizontal, you make a slight T so that you can reach it. But many times you can go up to, you saw in one patient, we have reached up to C5.
Would you still fix a C1, C2 POTS today if not having severe myopathy, or go ahead with collar halo and medical management?
Yeah, good question. See, now if I have only cold abscess, if I have only cold abscess, I drain it out, fix them with Philadelphia collar and give anti-tuberculous treatment. I fix it only when there is the facet is degenerated, either occiput and C1 or C1 and C2, then I fix it.
Do you prefer expandable cage or iliac bone graft?
I prefer iliac bone graft. Example, this expansible, this is a very tricky job, and it is more a little bit dangerous also. You have to use properly. Otherwise, if it fails, then there will be pharyngeal injuries, very significant.
Has there been any incidents of implant subsidence in your case series of anterior cervical surgeries?
Okay, see, implant subsidence comes only when you do standalone techniques. Like we discussed about in my last class, implant subsidence comes very less It mostly, usually, implant subsidence comes when you expose the cortical bone. When you decorticate, that is, the cartilage is removed. You should not remove too much of cartilage. Then you put any implant, it will subsidence. It will collapse. So you must have some sort of a good cartilage so that the cage holds well. Yeah. So it's a technical matter. It's a technical matter.
Okay, what is the best way to get biopsy sample for culture in case of failure of empirical medical therapy in CVJ POTS?
In CVJ anterior, you're talking about, can you repeat the question, John?
Yeah, what is the best way to get biopsy sample for culture in case of failure of empirical medical therapy?
I would say, I would like, I mean, I'm not able to understand it, but then I like to take a good biopsy for culture. That's why the exposure, because by needle, you don't get enough sample. The yield is less.
If you have to re-explore for some reason, do you go through the same incision?
Okay, yeah, it is a little bit difficult, but you can always approach from the opposite side. Not a problem. Same side, it is very easy because once you dissect and open, you believe me, even if you open after some time, you have a very good exposure. It will be there. The tunnel will be there. Yes.
Okay, Abadash Heridas asks from Tampa asks, I have an asymptomatic C2 odontoid fracture. How much listhesis do you look for in X-ray flex extension, or just watch and wait until symptoms develop?
Okay, you see, the C2 fractures depend on the type, the type of fracture. When we usually we don't take much of flexion extension, but we see gauge the type of the fracture. If the fracture is more horizontal, we think it is more susceptible for failure. So we like to fix it. But if the fracture is a little oblique and crosses very close to the vertebral body, we try to avoid surgery. So the angulation, if you ask me more than 5 millimeters, yes, it is significant.
Okay,
Hello,
Doctor.
sir.
Go ahead.
So, any role of posterior fusion is better than anterior for port spine, or preferably an anterior will be better? And
Okay,
if in cold abscess is present, what will be the approach?
you're talking about C1, C2?
Yes.
Okay, right. See, we do not know. See, C1, C2 on one side, if you have a facet is involved, and if you wanted to, if you need a fixation, then you can do it from the opposite side. That is on the left side, or if the right side is pathology, the left side you can do it. Otherwise, I prefer the posterior approach because the posterior anatomy is very good and it is very easy. Now, I think Goel is there, and the technique is very simple. Once you start doing it, the technique which he introduced is very, very simple. So you can easily do that from posterior. So anteriorly, you can always take the biopsy if it is anteriorly projecting cold abscess. Posteriorly, that I'm not showing those cases because here we are just discussing only on the approach. So I just put on the approach. I prefer to do the posterior stabilization.
Okay,
C1,
for C2 anterior screw, do you prefer always the bicortical purchase?
No, that is the teaching. The bicortical purchase is the teaching, but many times it is difficult. Bicortical purchase is many times difficult. Even if you see my first case, you believe me, there was a gap of 1 to 2 millimeters gap between the fracture size, but over a period of time there was a fusion. So what it says is that the teaching of you lag it, bring it closer is good, but then attempting to do that has caused some more complications. So what I do is I usually push the screw into the odontoid to the topmost and try to hold it. That's all. It fuses well.
Dr. Abhinav asked, have you seen kinking of the anterior C2 screw?
No kinking. No kinking. You mean after post fusion?
Abhinav, well, I'm not sure what he means, Doctor. Let me ask him. Dr. Abhinav, are you there? Could you clarify that question? he says, yes, yes, he may be in a bad bandwidth. Posterior fusion, okay.
I'm not getting that. You know, what
Yeah,
is it?
Dr. Abhinav, can you ask that question or clarify it in your chat question, please? He's posterior fusion kinking, post-fusion kinking, I think he refers to.
Okay, post-fusion kinking. Yes. Okay, right. That's a good question. That is in the ventral screw. Sometimes it even get fractured after a fusion. It's more of a more of a physiological phenomenon. The forces of fusion, even it fractures the ventral screw. But the orotoid is already fused, so there's no problem. No need to worry about it. I have one patient like that, but nothing will happen to the patient. Yeah, it's already fused. Yeah.
Okay, very good. Dr. Parthaban, I'd like to thank you very much. We're going to move on to the next presentation.
Thank you.
And people will be able to see copies of this video on our YouTube channel.
Thank you very
Okay,
much.
thank you, Doc.
Thank you. Thank you very much.
Okay, Dr. Goel, are you there in the on deck circle, as they say in American baseball?
I have to. I'm okay.
Dr. Goel, are you there?
Yeah.
Okay, you're on.
John, I'm very much there.
Okay,
And let me see, my internet continues to be quite unstable, so you will have to bear with me. I have no option.
okay.
Are you ready to bear with me, my
Yes,
dear?
we've been successful, knock on wood, for the last couple of weeks.
Let us see. And it will be more at 6:20, around 6:20 to 6:30 or 6:30. That is the time.
Okay,
Okay, John?
okay,
And little bit now, little bit, because Parthi has completed little bit earlier than
Yeah,
his scheduled time.
yeah. Atulji,
okay. Did we lose you, Doc?
Atul?
Yeah, I think we may have lost him already.
Yeah, John, yeah. Don't worry now, you are used to my,
Yeah.
There you are. You're revived from the dead.
I'm actually, trying to see if I have some options. Let me see. My problem is I'm stuck. Let us see.
Okay,
Actually, you can use the phone Wi-Fi.
Yeah, I don't know how to do it. That is the thing. It is the phone is right in front of me, but I don't
Okay.
know how to settle it.
Shall I tell you? You have the settings. You can go to the settings.
Yeah, this I have done, like hotspot on. I have
Hotspot
done.
on. Okay.
Yeah, now on this, how to do?
Then you go to you have a laptop. Your laptop is Apple
No, this is desktop Mac.
or desktop Mac. No, you
Apple.
see the Wi-Fi rings coming. The Wi-Fi rings.
Yeah, I will.
Click on that. The Wi-Fi logo is coming, Atul.
I think he's working on it. Just be patient and wait. I think he may have slipped off.
I don't mind taking questions in the meantime if there is anything.
Okay,
to
good idea.
discuss.
Good idea. Okay, any questions for Dr.
Okay, now you know what?
Okay,
Can you see my screen now?
not yet. Yes, yes.
Now this is the thing you are talking about, right? This my
Yeah, beautiful. Yeah.
There is on top. Yes. Yeah, click there. No, that Wi-Fi. That Wi-Fi. Come to that arrow is very close to that.
yeah.
Above.
Now what?
Above Atulji.
No,
You come
it's
to
too
that.
much unstable. Yes, now
Yeah. Click it. Click it.
somewhere.
There you click that.
Click the video, right?
Yeah, you click that.
This one,
that
create net.
Once you click that, it will.
Create
Yeah.
network?
Now you see.
No, I'm to create network.
No, 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 no. It will come as your hotspot, your phone. Which is your phone? Beetle?
Open
What is that?
network today.
No, no. What is that Beetle?
Yeah, that is what is that?
What
Beetle
is
is my
that?
personal home.
Okay,
That
but
is the home thing.
but your phone should come. No, your phone.
No, today is my internet is very
Atulji, your phone.
so this yeah, yeah. Yeah,
Your
phone
phone
is
name should come. Not
today is
great.
very unstable, unfortunately.
I usually in that
Can you
place,
hear?
once you open
My
your
personal hotspot is on now.
yeah, your personal hotspot, that name should come here. Below Beetle, Gundu, that place, that name should come. Your phone name should come.
No, no, it's too much unstable today.
It's okay. Take your time. Everybody can relate to computer. There you go. Well, it fell off. Everyone can relate to computer
No,
problems.
no, John, today is very unstable. I don't know whether to
Oh, well, keep
continue
trying.
or
That's all
whether
right. We've done it
to-
before. Let's keep trying.
Okay, let me see. I will call Party on
Yeah.
his phone to
Yeah.
get more information.
Okay.
Yeah, yeah, please.
No, what is the problem? What is the problem, sir?
Party, now I have hotspot on. Now what to do? Name, there is nothing coming up here. No name is. It is not coming. That is the problem. Should I? Oh,
Ike,
no,
can
it
you
is
walk? Can you
not
walk them
coming.
through?
That is
Ike?
my problem for a long time. Otherwise, I would have
Hello?
done it. There is no
Yes.
name coming.
Ike, you want to walk them through?
No, I'm just waiting here for Professor Goyal's talk. Let's see.
Okay.
Okay, let us see. Let me just start now. The thing is better now. Let me just start. Okay, whatever is there. Okay.
Okay.
Okay. No, no, name is not coming. That is the problem. Okay, let me just start, Party. Okay. 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 Okay, John, let's begin now.
Okay.
Rather than, struggle. And I know the young people who are there will be there. And those who will not be there will not be there. So
Okay.
let's begin, okay?
Okay.
John?
Okay.
Today is very unstable, but okay. Now you want to introduce or something? I may do it.
Ike, you want to introduce Dr. Atul? Are you there, Ike?
Yes.
Go ahead, Ike.
Yes. Yes. Good evening, sir.
Good evening. Good evening, my dear.
Yeah. So again, one more daily dosage today for neurosurgery during this lockdown, and we have Professor Goyal with us. So we've been watching his videos, and some of these videos speak about his spectacular experience as well as his operating philosophy, which is very, very different from a lot of people. I can only say that we are fortunate to have him on this daily dosage. And Parthiban's talk also, I was listening to it, and I am generally not somebody who's interested in spine at all. I probably haven't operated spine for the last 4 or 5 years, except in very, very rare cases. But then Parthi's clear explanations and, the way he is explained is excellent. I'm sure the young neurosurgeons are, enjoying it. And of course, No introductions needed for Professor Goyal. So please, sir, take the stage.
Okay, thank you very much. Today I'm going to present a real revolution for you. And I am sure you will enjoy it, even if you don't like spine. I must tell you, do you have my
Yes,
screen, John?
yes, we see it.
Okay, let's begin without any further ado, my dear friends.
Okay. A little slowage on his network. Just wait. Be patient, everybody. It usually comes out of this okay. Okay, he'll be back on momentarily. Whoop.
Okay. So,
Okay, you fell off the screen share, Doc.
yes.
Yeah, there you go.
So I am going to present to you a spinal revolution. Now you will ask me, what is this revolution? Is this word a little too much? That you have to decide after I finish today. And this is part one. I am going to have 4 or 5. So part one for today. And I can, just a minute. Part one for today, okay?
Okay.
Spinal surgery revolution. Just a minute. So we have to move, we have to fly, we have to do several activities like this eagle, and movement is life. But human beings are different than this eagle or this vulture, I don't know what it is. You see, when the vulture flies on its beautiful wings, and you see the majestic fly, pressure on the spine when the vulture is in air. So this is a very unbelievable kind of movement that this vulture has. And then you have a beautiful horse. You see the various muscles of the horse, and it runs on his 4 legs. So the spine is supported by 4 legs, and human beings are the only mammal, other than some gorillas maybe, who walk all the time on 2 legs. And this majestic horse is extensor predominant. And the center of gravity, center of activity, you see this beautiful horse. And when the horse stands on 2 legs, at that time it is 0 center of gravity. Extensor muscles are prominent. Extensor muscles are active. Flexor muscles are passive. All the movements of the horse are extensor active and flexor passive. So as I showed you, to bring out this concept as to what I am going to talk to you, I am going to come back to my very favorite slide of human pillar. Human pillar is a very unique pillar, and we stand on two legs. And this is our craniovertebral junction. And this entire spine is standing on very small focus point. So this is the human spine, and this is the atlantoaxial and occipito-atlantal joint, or the craniovertebral junction, and this is the rest of the spine. The whole human spine is extensor prominent. It means all the movements of the spine are conducted by the extensor muscles of the body. If you touch your neck from behind, there is a huge bulk of muscles, and there is not a single muscle anterior to your spine, except for very thin longus colli, which has a function of a curtain rather than function of an activity. The function of a curtain is to prevent showing what you are doing. On the other hand, the extensor muscles are the ones that perform or do. So all the muscles, despite the fact that there is body, there is disc, but very little muscle anterior. All the muscles are lateral, and all the bulk of muscles are posterior. So instability of the muscles, instability related to your muscle weakness, is the bottom line of your problems. There is no embryological issues in atlantoaxial instability. It is the muscles that make you unstable. An atlantoaxial joint, which is the most mobile joint of the body, can become unstable early in the life. And this instability has to be treated, if you have to treat, according to my understanding, from behind by sectioning all the muscles. If you have to stabilize C1, C2, you have to section the muscles. Unless you section the muscles, any implant put from front can be very heavily neutralized by these muscles. So this is my principle and my understanding, not to say anything about beautiful presentation of Parthiban. Essentially, all the activity is from behind in life, and the activity of surgeon is also from behind. So this is the technique that we had proposed for atlantoaxial fixation. Basilar invagination, we had proposed that it is due to atlantoaxial instability. I must tell all the listeners that this concept, which I am talking to you repeatedly, has not yet, was never understood before 15 or 20 years. Instability was not at all an issue in basilar invagination. So we introduced for the first time that basilar invagination is an unstable phenomena, and it can be treated by lateral mass fixation. So this is an issue of atlantoaxial instability is the issue, and stabilization is the treatment. This concept was never there in the literature. So this is quite a revolution in spine surgery. That is why somebody was asking me about decompression, and so I have said that decompression or removal of bone is not a treatment of any craniovertebral junction instability related issue. Like this is the problem. This is an unstable spine. You stabilize atlantoaxial joint. If you cannot, then you have to learn. You cannot say, I will do decompression because I cannot do it. If you cannot do it, do not do. But there is no excuse of doing a wrong operation. If I say I do decompression, then it is a wrong operation, and that you have to realize. I'm not trying to criticize anybody. I'm not trying to say anything about what others are doing in the world. And I am saying on a same eye contact level with all of you, even if you are residents in neurosurgery. So this is a huge basilar invagination. It can be reduced. So our concept was that all basilar invagination is an extensor muscle issue, extensor muscle related problem, and stabilization is the treatment, and realignment, if it is possible, is a good option. Listhesis, facet C1 over C2, like spondylolisthesis, we had said for the first time in the literature that basilar invagination is nothing but listhesis of C1 over C2. Like you treat listhesis, similarly you treat C1, C2 instability, and you see this is preoperative and this is postoperative in a beautiful alignment. Whether you get alignment or you don't get alignment, that is a secondary one. The issue is it is unstable, you stabilize. That is the issue. So facets are the strongest bones of the spine. Each vertebra, if you hold, they are the strongest facet. Vertebral body is the weakest. Spinous process is the next in line. Lamina is strong. Pedicles are quite strong. Facets are the strongest. There is no real muscle attached directly to the facets. There is no real muscle attached directly to the vertebral bodies. They are the fulcrum of the pulleys. They are not, the activities is there, but there is no muscle attached directly to the facets. I will show you this, what I mean. So facets are the key, and we have to learn the facts about the facets. So this was C1, C2 facet I have talked about. So there is nothing much attached to the facets. All the muscles are attached to the C2 spinous process, to the transverse process, and they relate and activate the C1, C2 articulation. This is the fulcrum of all movements. The facets is the center of activity, and the facets is the center point of the activity. And that is why fascial fixation as a mode of treatment we described for atlantoaxial instability. Now you see this slide, all the muscles are extensor prominent. As I had discussed yesterday about my philosophy of the disc is divine. Disc is the opera conductor. It conducts the whole movements without lifting any instrument in hand. It is like odontoid process. There is not a single muscle attached to the odontoid process. All the movements, this is the facet. These are the muscles, and these muscles act, these are the pulleys and act on the facets. So facet is the problem, not the problem, it is the site of activity of all movements. Disc is the conductor, conductor does not do any activity, but it is the brain of all movements. The brawn you can see, the muscles, brawn means muscle, B-R-A-W-N. So as I mentioned to you, instability is the cause of retroodontoid calcification or osteophyte formation. These are the osteophyte formation. For 20 years or 30 years, these were considered to be tumors, and these were considered to be abnormal, and these were considered to be pathological, and they were removed by transoral route or lateral, far lateral route, extreme lateral route. But we said that this is not any tumor. This is a response to an unstable spine. You do atlantoaxial fixation, and this will eventually disappear. So this is a landmark article of mine. And after that, there have been several further articles which said, yes, we have also found that the retroodontoid pseudotumor, as it was called, is not a tumor. It is a response. It is an osteophyte. It is due to buckling of the. Now, another statement you listen, which first time we reported in the literature, that when there is a listhesis of C1 over C2, there is buckling of the posterior longitudinal ligament, which initiates a bone formation phenomena or like a callus, periosteal reaction kind of phenomena by separation of the periosteum from the bone and this bone formation. So see, instability or instability is the primary problem. These are secondary, and in one of my articles, I had said that osteophytes are protective phenomena. They are not pathological. So this was my article in 2004, which I consider quite a revolutionary article stating that atlantoaxial instability is the cause of retroodontoid mass. Then subsequently, we reported several other articles, including retroodontoid cyst formation, which we said is due to buckling of the posterior longitudinal ligament. You stabilize and distract, and this can go in the immediate postoperative period, and there is no need to remove this so-called buckling and cyst formation in the retroodontoid area. So there can be a possibility of immediate postoperative disappearance of retroodontoid pseudotumor, as it was called. And subsequently, we have got several other papers. So this is another retroodontoid cyst, and you see this cyst is completely gone, and this is fixation. No attempt was made to touch this cyst, even if it is a very simple operation, but it is not necessary. So that is the philosophy number one that you must remember. Even as I had told you that this pannus is due to severe unstable atlantoaxial joint and buckling of the retroodontoid ligament, which we used to call pannus, and it was considered as pathological phenomena. So this pannus is due to buckling of the retroodontoid ligament and inflammatory response. So you do retraction and distraction and fixation, this pannus can be immediately gone. You see this buckling and this is gone. Only distraction was done in this patient, and this is the. So we introduced long time ago in the year 2000, about 20 years ago, we introduced these intra-articular spacers for the first time in the literature. Intra-articular, intrafacetal implants were introduced by us in the year 2000, and I had labeled this technique as joint jamming technique. And I used these spacers for the treatment of not only atlantoaxial instability, as I have shown you the other days, but I have used it for the treatment of basilar invagination, rotatory dislocation, and several other issues in the unstable phenomena of craniovertebral junction. Now I will come to degenerative spine. So this was my article a long time ago, and craniovertebral junction instability due to degenerative osteoarthritis of atlantoaxial joint. You see 108 cases in the year 2010. So this was the first time in the world literature that craniovertebral junction degeneration was described as in the first time in the literature. And we have described in such a huge number. So what I am trying to say is C1, C2 degenerative spine is a very common phenomena, although it is not understood or it is misunderstood and misdiagnosed. So in one of the lectures, I had said that atlantoaxial instability in craniovertebral junction due to degenerative osteoarthritis is the most underdiagnosed and undertreated clinical entity in the subject of spine. You see, this is craniovertebral junction atlantoaxial joint. This is buckling of the posterior longitudinal ligament, reduction in the joint space, osteophyte formation. So what we have said in our article, that joint space gets reduced due to vertical dislocation of the atlantoaxial joint. Vertically unstable atlantoaxial joint will reduce the joint space. It will initiate formation of osteophytes due to buckling of the posterior longitudinal ligament. So essentially what was described is that joint space reduction is not a primary phenomenon. Ligamentous buckling and osteophyte formation is not a primary process. All these are indicators of atlantoaxial instability. And when you see osteophyte, when you see joint space reduction, when you see buckling of the ligaments, it is a clear indicator of an unstable atlantoaxial joint, and you need stabilization. Bone formation in the region of odontoid tip is never a congenital problem. It is an osteophyte in the apical ligament, and it is an indicator of an unstable atlantoaxial joint, and it is an indicator for atlantoaxial stabilization. Do not try to unnecessarily disturb this odontoid tip. So when you see ossification in the region of odontoid tip, it is a clear indicator that this region is unstable. When you see osteophytes like this, it is a clear indicator of an unstable atlantoaxial joint, even when there is no deformation here. So that is one thing which is a revolution, I can say. Buckling of the ligamentum flavum that you see so often was in the entire history of this subject. Buckling of the posterior longitudinal ligament, osteophyte formation in the entire history of degeneration has been considered to be a pathological phenomena, but we said for the first time in the literature that these are not pathological, they are response to the unstable spine. Similarly, if you see the lumbar spine and cervical spine, if you see disc space reduction, this is a clear evidence of an unstable segment. Osteophyte formation, if you see osteophyte formation, it is a clear evidence of an unstable spinal segment. If you see disc bulges like this, these are not a primary pathological phenomena. If you see ligamentum flavum bulges, if you see disc bulges, these are not primary processes. They are indicators of an unstable multi-segment of the spine. So this is a revolution. This has never been described in the literature. So you please try to understand what I am saying. If you see the entire literature on degenerative spine of last 150 years, the first sentence in that literature survey will be that the disc space is reduced due to reduction in the water content of the disc. Space is reduced due to age-related disc degeneration. And then it leads to osteophyte formation. And then it leads to compression. So this is what is described in the entire 150 years. And still, if you see today, all the entire literature on degenerative spine is focused on disc space reduction, which I am saying is not a primary process. It is an evidence of a spinal degeneration. This is not degeneration. This is a secondary phenomena to spinal instability. Osteophyte formation, buckling of the ligament, disc bulges are not primary processes. They are due to unstable spinal segments. So we proposed a very novel concept. There is a vertical facetal instability. So this article of mine, I will consider it as an entire absolute revolution in the field of degenerative spine. That there is a vertical spinal instability, a problem that we are facing due to standing human position all our life, and due to weakness of muscles of extensors, extensor muscle, erect spinal posture, weakness of the muscles leads to telescoping of the vertebral segments or vertical spinal. So if you see C1 over C2 listhesis, as we had labeled as basilar invagination, similarly, there is reduction in the facetal space and facetal listhesis, which has never been reported in the literature. Even this was never reported
Okay, I think we have a temporary freeze. Just hang in there. Usually resolves in a minute or two if we're lucky. Okay, continue to wait. He'll come back. He always does. Are you there, Dr. Goel? Are you there, Dr. Goel? Okay, he'll be back. Still standing by.
Hey, John. Yeah, is the talk the Jordan Grand Rounds right after this, or is it
Yeah,
around?
it's right after this and in about half hour.
Okay, fantastic. Just wanted to confirm.
Yeah. Oh, I might as well. I might as well make that announcement now.
Yeah.
Now that we have time, to everyone out there, we have a Jordan Neurosurgery Grand Rounds with Dr. Ibrahim Sabaya, a well-known Jordanian neurosurgeon and medical educator who has been doing these Abalash for 27 years. Before the internet, he was doing multidisciplinary weekly presentations, and now he's using the internet to get the Arabic neurosurgery world involved.
Yeah, I'm looking forward to it. I have a case coming up next week, so it's going to right up my alley.
Oh, really? Orbital tumors?
Yeah.
Oh, good. Yeah, you can interact with him too.
Yeah, I'm
and
looking forward to it.
you know, and then kind of brainstorm with him. So, okay. Well, maybe you can use this time to. Oh, here he is. Okay, Dr. Wells here. Okay, there he is back. He always comes back.
Yes, John, I'm there again. with you,
Okay,
my-
go, okay, carry on.
You know what? These young people, I know they are getting troubled, but if you want to see something out of the world, then you have to see, you have to handle this trouble. Don't worry.
That's okay.
Okay. John, now I start again.
Okay,
So we introduced a very novel kind of a surgical technique where we did facet distraction, introduce facet distraction spacers in the treatment of degenerative spine. So in this technique, there is no question of any decompression. I will show you. So facet distraction arthrodesis technique I am going to show you today, and can it revolutionize the treatment of spinal degeneration? So this technique is facet distraction arthrodesis technique. So this is a new philosophy, an alternative method. There is no alternative. This is the technique, and this is the revolution in the treatment. And when I say it is a revolution, it is not in air. It has been published very heavily. And you see it was published in the year 2011. And before that, in 2010, it was also published on the pre-print publication of this Journal of Neurosurgery. So this is not a technique which is just in air. It has been heavily published, and also it has been quite heavily followed in the world. So those young people who are having a feeling that this is some kind of a hypothetical treatment, you please remove that from your mind. Many people in the world, and if you go home and see later the literature on this subject. So this was the revolution that I am going to present to you today. And this article of mine was published as a cover page of Journal of Neurosurgery. It was on the cover. And these are the spacers that we had introduced at that time. So if you hold the vertebra in your hand, and there are several articles of mine on the morphometric analysis. You see, this is the huge facet. It is the strongest part of the vertebra, and it is obliquely inclined, like this oblique inclination. And we had measured all the inclinations, and this is the vertebral artery in relationship. All kinds of morphometric measurements were done by us. So those who want to go further in this technique must read several of these articles where morphometric analysis of the cervical facets has been described to introduce Goel. We had labeled them as interfacet spacer distraction technique. So this was another paper for lumbar spine. So this was, if you realize, this was for cervical facets, and this was for lumbar facets. So now here, you see, these are the very big and strong facets. So this standing, my concept was that this can never go wrong. It is a divine structure. This is divine. This is an absolute miracle of body. What happens is the human body is not used properly. It is abused, misused, or malused, or injured when these muscles, which are focused on the fulcrum point of the facet, this becomes weak and the facet dislocates vertically, or vertical instability of the facets. So there is vertical instability of facet. This cannot be seen on the conventional CT scan or conventional MRI, but basically you have to understand, you may not see this, but the effects of this instability is the osteophyte formation, the buckling of ligament, and the reduction of the disc space. And we introduce these kind of spacers. After, you see, this was the normal. Here we have, this was the abnormal one. and I have distracted and introduced this spacer, and I have realigned the facets. So this is what I'm going to show you. See, this is the osteophyte. This is the joint space reduction or disc space reduction. This is the ligamentum flavum buckling. So what I had said for the first time in the literature, that this buckling is not primary. This ligamentum flavum is not primary. This is not pathological. This is not a disease. This is not a disease. This is not a disease. This, of course, can never be diseased. You do distraction and you can get a new disc here, and this ligaments can unbuckle, and this ligament can unbuckle, and most importantly, and more importantly, the patient will remarkably recover in the symptom without any decompression. No laminectomy, no ligamentum flavum removal, no osteophyte removal, no disc removal. If you ask anyone in the audience, this is a very clear case of single level ACDF. You come, remove the disc, osteophyte, and then do whatever you have to do. But this is not the treatment. This is a wrong treatment, because what it needs is distraction, reduction, and fixation by this kind of goel facetal spacer. This is another case. You see the osteophyte, you see the disc space reduction. These are clear indicators of an unstable segment. And when this is unstable, you have to do fixation and you have to do insert intra-articular facetal distractor, which is the most physiological way of achieving the distraction, reduction. And you see the disc space has a little bit increased, and eventually these osteophytes will disappear. This is another case. You see the osteophyte, very big osteophyte. You see the buckling of the posterior longitudinal ligament. You see the buckling of the ligamentum flavum. This is postoperative. The osteophyte is gone. The ligament. This is immediate postoperative, and you see a new disc is formed. Disc is what? Water, and this T2 weighted hyperintensity in the disc space is a new disc formation which gets formed. Multi-level disc degeneration, I do not like this word disc degeneration. Divine disc can never get degenerated, but this is in our mouth. This is all the time. Thank you.
I'm sorry.
You see these fusions is never primary. It is never primary. It is an evidence of an unstable spine. Treat. You see this osteophyte. This is Hello, John.
Yeah, go ahead. I had to mute everybody. Go ahead.
Okay. Now, if you see this joint space reduction or disc space reduction, osteophyte formation, these are divine interventions. These are not to be touched. These are introduced by God. Don't try to be against God. God is on our side. It is a repair machine. It can repair you without any problem. You see the interfacetal space and you see the spacer, and you can imagine how the space in the root canal will be increased, in the spinal canal will be increased. You just keep your open mind when you are seeing this. You see this? These are unstable spine. Now, how to identify this unstable spine? That is on your clinical parameters, radiological parameters, and you see there is joint space is increased, and these are spacers, and ultimately this will lead, this is some bone, and ultimately this will lead to bone fusion. You see this multiple, and these are 3-level stabilization, and these are intrafacetal spacers. Preoperative, you see unstable facetal articulation. This is another spin, multi-level, degeneration, multi-level divine intervention for unstable spine. And you see this immediate postoperative, you see this is not yet gone. This hyperintensity in the cord may not go, but you see this one and you see this one. Most importantly, the patient will remarkably recover in the immediate postoperative period. So this is multi-level spinal degeneration, also associated with OPLL a little bit. I will talk about OPLL in my revolution number 3. Today is revolution number 1 I am talking about. So this is intrafascial spaces at 4 levels. Intrafascial fixation is the treatment. Stabilization is the treatment. Decompression is not the treatment ever. Believe me, decompression is never the treatment. You please remove it from your psyche of as decompression. So this is buckling of the posterior longitudinal ligament. This is immediate postoperative. I will show you. This is another case of buckled posterior longitudinal ligament. This is postoperative new disc formation, and this ultimately what has happened is not a radiological cure, may not be there, but this has been stabilized, and that is what matters more. This is stabilization of this area. This is postoperative. You see, this is preoperative, and this is the spacer in the fascial articulation. This is the spacer in the fascial articulation, and you have seen. Now, another thing, you see there is a buccal posterior longitudinal ligament. The whole world, an entire lot sitting in front of me in the panel will come from front and remove this. I was doing this thing all the time, but this is not necessary. Fascial distraction is the treatment. Stabilization is the name of the game, and immediate postoperative reduction of the herniating disc as well. I will show you better images after some time. This is pre-op and post-op. You see the disc space has increased, the intervertebral spaces are increased. More importantly, the spinal canal is increased and the neural canal is increased. You see the space here, and you see the space has increased. Articulation, there are spaces. You see this foramen is increased to a tremendous level, and intraspinal volume is increased to a great level. This is another case. You see preoperative, there is a fascial space reduction, and this is after 1.5 years. You see there is arthrodesis of this joint C1, this whatever joint is there. Bone, this is the fascial articulation. There's spacer here, and this is the bony fusion that you are seeing in the space. Fusion is the answer. Arthrodesis is the answer. Decompression is a redundant or a negative form of treatment, either from front or from behind. So this is my philosophy, and this even with 3-level fixation, you can have a good spinal movement. Now you see this is preoperative. After 1 year, we have put this spacer, and you see this bone fusion after 2.5 years, and you see this bone fusion. This is preoperative osteophyte, and post-op, this after 2.5 years, you see the osteophyte is disappeared, and there is a bone fusion in this territory. This is the osteophyte. You are seeing multi-level osteophyte. You see the osteophytes are gone, and this is after 2 years. You see there is no decompression, and there is no compression. So this is what I have to give you, this message that decompression is never an answer for degenerative spine. You see this is preoperative, and this is after 2 years. You see the spacers, and you see the bone fusion. If you carefully see, the spinal canal is increased in spine, increase in size, root canal is increased in size, and the patient has completely been cured. This is another patient. You see the bone fusion here after 6 months, and after 2 years, there is complete bone fusion. And you see that there's reduction in the joint space, opening up of the joint space, fusion. You don't see this articulation. What you see is the root canal, which will be increased, this space, which will be increased. And more importantly, the region will be stabilized for you for complete arthrodesis. This is, you see, preoperative multi-level bulges, not this multi-level divine intervention of osteophyte, indicators of unstable spine, And this is after 1 month, you see the osteophyte is completely gone, and you see the stabilization, no decompression, and this is the treatment. This is another one you see, multi-level spinal degeneration. Oh, what degeneration? Multi-level spinal divine intervention of osteophytes and multi-level degeneration. You see the new disc is formed here. Ultimately, there will be arthrodesis, and there is a big space for the spinal canal. This is another case. You see multi-level divine intervention by disc space reduction, and you see that disc space has been increased. Osteophyte will eventually decrease in size, and there is an increase in the spinal canal dimension. You see there is quite a large osteophyte, and this is the one. You see osteophyte is, the disc space is increased. Can you compare this and this? Quickly compare, and you see there is no compression to the spinal cord. This is another case, beautiful case, beautiful case. You see there is increase in the joint space, increase in the joint space. There are interfascial spaces. There is no decompression. You see this another case, there is a osteophyte, divine intervention, and this is human intervention, and this is the reduction in the osteophyte after a period of time, and there is, of course, ligamentum flavum unbuckling. And now you see a beautiful case, my dear young friends, and believe me, keep yourself, don't argue with me unnecessarily, okay? Don't argue. Don't forget about it. Do whatever you comes in your mind and has been, but if you keep your mind supple, you better keep it supple. If it is not supple, forget about it. Okay, what I'm saying is don't even think about it. But what I'm showing you is a complete revolution, and it is eventually going to take over. So better you understand it now. You see divine intervention here of ligamentum flavum buckling, osteophyte buckling, and this is post-operative. You see the entire ligamentum flavum gone, buckling is gone, and the patient remarkably beautifully improved in the immediate post-operative period, and you see intrafascial space. There can be immediate post-operative. Whatever I'm saying to you, dear friends, is all published very heavily, and several people in the world are doing this. So don't think it is, don't try not to learn or forget, oh what, oh hypothetical, this kind of nonsense. There can be immediate post-operative reversal. I have discussed this article long time ago. I have shown you this image. This is immediate post-operative finishing of this by introduction of these intrafascial spaces. You see this large divine intervention, and it is gone. Ligamentum is proper. Ligamentum flavum is beautifully, and there is a beautiful arthrodesis of this segment of the spine. So these were my fascial intra-articular spacers, and these are the spacers. This is a concept, and there is emergence of the concept. We had introduced this concept 16 years ago. Don't think that it is a brand new concept and I have just come and suddenly I have got an idea and showing to you. And also it is my patent. In America also it is patented. You see, there are 2 patents of mine on this subject. It is not only the implant, which is, carefully read, device and method. Device is also patented, and the method is also patented in US. Now you carefully see my implants, which I have labeled them as Goel facet spacers. Company Jesco is making in India. The CEO of Jesco company, and he can work out this thing for you. I'm not trying to do any kind of a commercial things on you, but just see what I'm showing. And this is also patented in India, and this is the patent certificate. There are 23 patents of mine in India, and you can go through this patent certificate. So this is my design of my patent. Outer diameter is this much, this height, this height. There are multiple kind of sizes of this facet spacers. This is the front view, lateral view. There is a hole here for the implant holder, and there has been, this is the facet spacer in the spine, which has been heavily biomechanically assessed and learned. So same concept I have used in the lumbar spine and introduced intra-articular facet spacers in the lumbar spine on one segment and multiple segments. And this was also published in the Journal of Neurosurgery. So it is distraction of facets with intra-articular spacers as the treatment of lumbar spinal canal stenosis. And this was another article which we had published on the subject. And this is biomechanical studies on the subject were carried out in one of the world's largest biomechanical institute in Toledo. And they had studied the biomechanical properties, and they have, you can read this article where they have said that this spacer is better than any other implant in the spinal fixation constructs. This is another biomechanical studies. They have studied the lordosis, height, and all those things, and they had come to this conclusion. So this is my relevance of my hypothesis regarding pathogenesis of degenerative spondylosis and its implication in facet distraction surgery. So this is my revolution number 1. I will come to you, my revolution number 2. I will give you some time for digesting this revolution first. So I will not land up with you tomorrow, maybe after 1 or 2, 3 days.
Okay, Doc?
John?
Yes,
Yeah,
yes. Yes, so thank you very much, Dr.
So-
Goel. And I'm sorry.
I hope, no problem, John. I want to ask the people, whoever are sitting here, if they liked it, they should put on the chat box, yes.
Okay.
And if they have not liked it, I want them to put it on the chat box, no.
Okay.
Please do it for me. I want to have the response.
Oh, yeah, I
because it
already
is my
have 5
personal-
yeses. I already have 5 yeses.
Let us, no, don't divulge. Still, let them
Okay.
do it.
Okay. Well, Doc, I'd like to thank you very much. Unfortunately, Dr. Ibrahim Sabaya has a lecture from Jordan, and we're kind of late starting his because I only have one Zoom account. We're getting really busy here. And I have to get another Zoom account to accommodate you, basically, because of your number of followers. So we look forward to seeing you when you can in a couple of days for part 2, correct?
Yes, yes. I want to give this concept for people to digest and to understand so that I can give 1 or 2, 3 days gap before I come with another revolution. So I have told you I am going to give you 5 lectures and I am going to completely revolutionize spine surgery for you. If Ip is there, I would like to have his comment. He's not there, it seems.
Okay, IP,
Is
you
there?
there?
No.
No, we paid it.
he's not
Okay,
a
doctor.
spine-
Okay, doctor. Thank you
Okay.
very much, and I have to end this. I'm sorry.
Okay, John. Thank you very much.
I'll see you
Bye-bye.
next time.
Bye-bye.
Bye-bye.
Bye-bye.